ahead and get started. My name is Musi. I am the director of the Geriatric Research, Education, and Clinical Center here in South Texas, VA. So I welcome you to this third day of the Summer Institute of Aging, which has been going on for 25 years now. And I also welcome the people who have joined us on VTEL. So today you have a number of talks that have addressed an important issue in the community at large, and it's an issue that is even more prevalent in our older patients, which is diabetes. So I'm going to start by giving you some numbers regarding the epidemiology of diabetes and how it relates to aging. I'm going to spend a fair amount of time discussing the pathophysiology of diabetes in the elderly. So I'm going to go back to your classes on physiology and biochemistry. And so I hope you enjoyed that part. And then I'm going to go over clinical scenarios and give you some general recommendations regarding management of diabetes in the elderly. Originally, we are scheduled for 2 hours, with the second hour addressing treatment of diabetes in the elderly. But what I'm going to do, I'm just going to merge them so we can finish. So we'll finish approximately by 9:30. Okay, so what this figure shows is the worldwide estimates, actually the worldwide cases, a number of people that have diabetes across the world. So what you can see is that diabetes has been increasing progressively, but just know between 2000 and 2010 that approximately there is about a 50% increase in the cases of diabetes worldwide. So obviously this is very, very concerning. In just 10 years, the cases of diabetes have increased by about 50%. So most of us now probably well know why diabetes is such a concerning problem, because having high blood sugar is it's very bad to our body, it's bad to our cells. So high glucose concentrations are toxic to the blood vessels in our retina. So diabetes is the number one cause of blindness in our country and in most developed countries. High glucose is very toxic to the cells in our kidneys, but our blood vessels in our kidneys and other kidney cells. So diabetes is the number one cause of dialysis and kidney failure and kidney transplants in our country. And diabetes also is very toxic to the small blood vessels and nerves in our extremities and throughout the body. So diabetes is the number one cause of neuropathy and amputations. So these are very serious problems that we need to deal with. We need to treat diabetes, but we need to do a better job in preventing it. But in order to do this, first we need to understand why diabetes is increasing so fast. So one of the reasons diabetes is the rate of diabetes is increasing so fast is fairly obvious to most of us, and that has to do with the increasing prevalence of obesity. So as people not only in our country but around the world are eating more because they're more the availability of foods and calories has increased, and around the world people are eating more and also being less physically active. So our body stores that extra calories in the form of adipose tissue, and to a very large extent this adiposity is driving the increase in diabetes. But the other less recognized reason why diabetes is increasing so fast is that people are living longer. So as treatments for many diseases such as infectious diseases, cancer, atherosclerosis, which are very important causes of mortality. So as treatments have improved in the last few years, people are living longer. And aging, independent of any other risk factor, aging itself per se, it's a major risk factor for the development of diabetes. So what is driving this increased rate of diabetes is both obesity and increase in longevity. Now they often go together. There's also an increase in obesity with aging. Now this, to illustrate the increased rates of diabetes in aging, I have this figure. So this figure is basically showing the prevalence of type 2 diabetes and what we call pre-diabetes or IGT. So how are these cases recognized? There are different ways to diagnose diabetes. One is with a fasting blood glucose measurement. And in general, it's said that if it's 126 milligrams per deciliter fasting or higher on 2 occasions, that makes a person diabetic. The other criteria has to do with diagnosing it with a glucose tolerance test. So basically, this is a test that in clinic is seldom performed, but for research purposes, we do it more frequently. So the standard glucose tolerance test, people ingest 75 grams of glucose drink, and then glucose is measured in plasma after 2 hours. And if it's 200 or higher, a person is thought to is said to be diabetic. If it's between 140 and 200, a person is considered to be impaired glucose tolerant, or IGT, which is the same as being glucose intolerant, and it's also the same as being pre-diabetic. Why pre-diabetic? Because this person has about a 50% chance of becoming diabetic in the next few years. And if a person blood glucose at 2 hours is under 140, that is considered normal glucose tolerance. Now, you might imagine that this is a dynamic process, right? If you are very close to on the other side of the fence, then that is a problem. So that is these are not very hard barriers or lines, but it gives us a general idea. So based on this criteria, you can see the rates here of pre-diabetes, but also of diagnosed cases of diabetes. Those are cases basically both the patient and the physician know the patient has diabetes. But for every person that has diabetes, it is estimated there's another person that has diabetes and doesn't know it. So we call it undiagnosed diabetes. So you can see that all of these increase with age. So if a person has 65 or higher, it has a 50% chance of being diabetic or pre-diabetic. Or in other words, 1 in every 2 people aged 65 and older have diabetes or pre-diabetes. So why diabetes risk increases so much with age? Now I'm going to go through some basic concepts of type 2 diabetes. Now, so far I've been saying type 2 diabetes, and I haven't mentioned type 1 diabetes. So just to give you some idea of the differences, basically diabetes mellitus, because there's another form of diabetes, which is called diabetes insipidus, but that's rare. Diabetes mellitus, which is what we often think of diabetes, means high blood glucose concentration, right? And in general, there are 2 major types of diabetes. One is called type 1 diabetes. It used to be called juvenile diabetes because it's seen much more frequently in children and adolescents. But it can also occur at any age. So there are people that can develop type 1 diabetes even when they're middle-aged or older. But because of this, now the term juvenile has been removed, and now it's called type 1 diabetes. Type 1 diabetes is basically when the cells that produce insulin in your body are destroyed by your immune system. So, as you know, there are autoimmune diseases in which our immune system basically recognizes a specific element of our body as a foreign entity and attacks it. So in the case of type 1 diabetes, our immune system thinks that the cells that produce insulin in our body, which are called beta cells in the pancreas, it thinks that it's something that it shouldn't be there and attacks it and destroys it. So basically, type 1 diabetes is an autoimmune disease in which the beta cells that produce insulin get destroyed. And these patients have very low insulin levels, and therefore the treatment is insulin always. The type 2 diabetes, in contrast, it used to be called adult onset diabetes because it's seen more often in adults. But because it can also happen in children, and as obesity is seen more and more in children, and type 2 diabetes cases are increasing in childhood as well, this term of adult onset diabetes has been eliminated, and now it's called type 2 diabetes. And the difference between type 1 and type 2 is that type 2 is not an autoimmune disease. There's no, the immune system is not attacking the cells in our body. What is happening is basically our cells, our beta cells in our body are producing insulin, but this insulin is not working efficiently in the body to maintain normal glucose levels. And I'll talk about that a little more. Now, in the elderly, by far, probably 98% of the cases are type 2 diabetes. Of the cases of diabetes are type 2 diabetes. So that's why I'm focusing more on type 2 diabetes. Type 2 diabetes typically is treated by different methods, including lifestyle interventions like exercise and nutritional therapy, weight loss. There are a number of oral medications. There are newer injectable agents that I will mention. And of course, it can also be treated with insulin. But in contrast to type 1 diabetes, there are many options. Type 1 diabetes really has to be treated with insulin. Okay, so in order to understand the pathophysiology of type 2 diabetes, we need to understand the normal physiology. So basically, in normal circumstances, when we ingest a meal, all these different nutrients enter the gastrointestinal tract, and then they are absorbed into our bloodstream through the stomach and the gut, right? So these nutrients are many, which are carbohydrates and others, that make our blood glucose levels to start to rise after we eat, right? So of course our cells in our body need some glucose. So that some of that glucose that is increasing in our blood is important for the cells. But as I mentioned, high glucose levels is very toxic to the cells in our body. So how can our body maintain a normal glucose level within a normal range? Well, there are different mechanisms, but one of the most important ones is the release of insulin by the pancreas. So the beta cells in the pancreas, which is shown here, this is the pancreas. Those beta cells detect the rise in glucose after we eat, and they respond by releasing insulin, right? Now, insulin will maintain blood glucose concentrations, will help maintain it within the normal range through different mechanisms. One is that insulin will work on the muscle. Well, what will insulin do in the muscle? Well, it stimulates those muscle cells to take up the glucose. So that glucose that is in the blood, the insulin will make the muscle cells start taking it up for metabolism, to be oxidized, but also to be stored. The other key mechanism by which insulin maintains normal glucose levels is by regulating the amount of glucose produced by the liver. So the liver is constantly taking up nutrients, and then it makes new glucose from those nutrients and releases it into the circulation. That is happening constantly. Insulin regulates this process. In the absence of insulin, the liver makes very large amounts of glucose. So basically, the insulin puts the brakes on the liver and makes it stop or reduce the amount of glucose that it makes. So another mechanism by which insulin helps maintain glucose levels within the normal range after we eat is by reducing the amount of glucose that our liver is making and releasing into the circulation. And the other important mechanism by which insulin controls glucose levels is by working on the adipose tissue, although I will probably stay away from that today. Now, one of the first things that happens in the natural history of type 2 diabetes is that there's resistance to the actions of insulin. So let's assume that there is a person who has it goes through childhood of being healthy, through college, and it's active physically, and is watching their diet, etc., and they have normal glucose levels, and all these processes working normally. But then, for whatever reason, this person starts exercising less. Let's assume he gets a job, and then it's all day sitting in front of a computer, so it's not exercising anymore. And it doesn't have much time to eat healthy, so it's eats fast food all the time and starts gaining weight. So these increase in weight gain and decrease in physical activity makes the tissues in our body to be resistant to the effect of insulin. That's what we call insulin resistance. That means that the body is making insulin, however, the muscle is not taking it up properly, and the liver is making more glucose than it should. Now, our beta cells in our pancreas, they're pretty smart. So they say, oh, okay, this fellow here is not exercising anymore and is becoming insulin resistant and overweight. I'm going to work harder to overcome this insulin resistance. So the beta cells can increase the amount of insulin by 1-fold, 2-fold, 10-fold, 20 times in order to overcome the insulin resistance and prevent that person to become diabetic. That means there's still not, glucose levels will still be normal, but that is because the insulin is just, the beta cells are releasing a ton of insulin. And then approximately in 80% of these cases, the beta cells can do this for the rest of that person's life. In other words, that person might remain insulin resistant for the rest of their lives, but not diabetic, because those beta cells can compensate for many, many years. But in approximately 20% of people that are insulin resistant, those beta cells cannot keep up for a long period of time, and eventually they fail. That's called defective beta cell secretion. That is, for some reason we don't understand, probably it's a genetic predisposition, those overworked beta cells fail in approximately 20% of cases. That's when the person becomes diabetic. So for a person to become diabetic, two things need to happen. First, they need to be insulin resistant, and the second is their beta cells need to stop working properly. So one essential question in the field of aging and diabetes has been, which is this main problem with older people as we age? Is it because our tissues become insulin resistant, or is it because the beta cells stop working properly as we age? So I'll show you some data. So this is from one of our studies. in which we enrolled basically 3 groups of people. People that were young, they were not diabetic, they were healthy people, they were between 80 and 30 years of age. Those are shown in white. And then older people, older means 65 and higher, the mean age was approximately 75 years old. They were healthy, they were non-obese, because we just wanted to look at the effect of aging, not of the effect of obesity. And they were normal glucose tolerant during a glucose tolerance test. And older patients who are, again, healthy, they were lean, but they had impaired glucose tolerance, meaning they were pre-diabetic based on the glucose tolerance test, which is shown on your left. So what we did is we gave them the glucose drink, and we measured glucose levels and insulin concentrations as a measure of beta cell function. How well can these beta cells release insulin in response to a glucose challenge? So let's focus first on the blood glucose levels in the young person. So they take the glucose, and obviously glucose starts increasing by 15 minutes, and by 30 minutes reaches a peak. Now look at what's happening with insulin, again on white to your right. Insulin, as these beta cells detect the increase in glucose, and they release a very large amount of insulin. See how high it goes, between 30 and 45 minutes. Right? So in young people, healthy beta cells respond very well, rapidly, and robustly by releasing a lot of insulin. Not only that, but in the young person, that insulin has been secreted. Look at the 45-minute time point. This insulin will work properly. It will work to reduce glucose levels. So see how there's a peak at 45 minutes in the insulin concentration on your right, and then by 75, 90 minutes, etc., glucose levels are decreasing. And the beta cell can also sense this and say, okay, I released a lot of insulin, and it's working, those glucose levels are going down, I'm going to stop making insulin, and insulin levels go down rapidly. So that is a healthy response. That happens typically in young people. A fast, robust secretion of insulin, and then that insulin that works properly, and then insulin stops being released. Now let's look at older people that were normal glucose tolerant. That is, people that are non-diabetic. Those are shown in pink. So they take the glucose drink, and glucose levels start to increase. Then let's look what happens to their insulin release on your right, again on pink. There is secretion of insulin, but the amount of insulin that is being secreted is not as high as young subjects. Therefore, the glucose concentrations remain elevated. They're not high enough to be considered abnormal, but in comparison with young people, there's certainly, you can see that the amount of insulin being secreted is lower, and that glucose concentrations stay higher. Now let's look at the older people that fell under this glucose intolerant range, this pre-diabetic range. Those are shown in green. So they take the glucose drink, and you can see on your left that glucose levels stay elevated, and that the amount of insulin being released initially is much lower than the young subjects, that is in green to your right. And therefore, the glucose concentrations remain elevated. Eventually, the beta cells secrete enough insulin. If you see the later time points of insulin concentration on the green, but that is too little, too late. By the time the beta cell starts capable of releasing the same amount of insulin, and the young person, it's at a much later time point. So that's another characteristic of aging, but also pre-diabetes, is that the release of insulin is not only insufficient, but also it's at the wrong time. That is too late. So I'm showing you this because to illustrate that as we age, indeed, there is a decline in the ability of our beta cells to release insulin, and that's a key factor that predisposes people to become diabetic. Now, why would our beta cells stop working properly as we age? We don't really know. And it's very hard to study this area because, of course, the pancreas is a very tough tissue to obtain and to study in people because it's located behind the stomach. So basically, it's impossible to take samples of pancreas in subjects, and we can do it in cadavers, but in cadavers, usually by the time you're able to get the tissue, there have been significant changes to study it properly. But there are some studies, both in humans and in rodents, suggesting that as we age, the ability of our beta cells to replicate is reduced. So our beta cells, just as the cells in our skin or in our gut, etc., are constantly being dividing and replicating. So it is possible that as we age, the ability of those beta cells to divide, it's reduced. So here I'm showing you beta cell failure on your left as a important factor predisposing to diabetes as we age. Now, the other factor that I'm going to spend more time on this one has to do with insulin resistance. As I mentioned, for a person to become diabetic, it must develop insulin resistance. So an important question has been, do our tissues, and I'm going to specifically the skeletal muscle, which is very important because, as I said, it takes up the glucose that it's in our body in response to insulin, and it takes it up to metabolize it, but also to store it. So does our skeletal muscle become insulin resistant as we age? And in general, it is thought that indeed the ability of our muscles to take up insulin, to take up glucose in response to insulin decreases as we age. And this occurs for several reasons. One, it has to do with low physical activity. So as we age, we tend to move less, in part because of changes in our lifestyle, but also because our body is changing. So people develop frailty, they develop weakness, and then they start moving less. So it's a vicious cycle in which the person moves less because that person is getting weaker, but at the same time, moving less makes the muscles weaker. So it's a vicious cycle that needs to be broken, probably through exercise interventions. But so the low physical activity makes our muscles insulin resistant. The other is sarcopenia. Sarcopenia means a decrease in the amount of muscle that we have in our body, and also in its function. So, as I mentioned, if the muscle is the main site where glucose is going to be taken up, and we have less of this muscle, then there is less of this reservoir for taking up glucose. So, having less muscle and more fat, referred here as sarcopenia, also predisposes to insulin resistance as we age. The other factor is visceral adiposity. So in general, as we age, our belly tends to get a little bigger, and that is because there's an accumulation of adipose tissue inside our abdominal cavity. And that fat is thought to be really bad for the rest of our body because it's like a niche. It's like this place that a lot of bad substances are being produced and released into the circulation. So the adipose tissue inside our abdomen makes a lot of inflammatory proteins, what we call cytokines. So these are proteins that go to the rest of our body and produce an inflammatory response that is thought to play an important role in the pathogenesis of diabetes, cardiovascular disease, neurological diseases, etc. But also this fat that we have inside our abdomen it harbors inflammatory cells, monocytes, T cells, etc., and it's like an incubator of inflammation. So visceral adiposity also is an important risk factor. And then the fourth one that I'm putting there, that refers to decreased insulin action. That means if you're able to control for the other three, meaning that if you find people who have older but have normal physical activity, don't have sarcopenia, don't have visceral adiposity, and of course there are a lot, not all people are like this. There are older people that are fairly healthy. Those people also have impairments in insulin sensitivity. That means a muscle cell of an older person who's otherwise healthy, that muscle cell functions normally. And I'll show you some of our data. That is a very controversial topic. There are people that think that, of course this is based on studies, that if you control for all the other things, aging and an old muscle cell can function properly. There are other people that think that muscle cells, even if you control for other things, that old muscle cells don't function properly. So I'll show you some of our data. So first question is, are older subjects more insulin resistant? So how can we measure insulin resistance? Or insulin sensitivity? There are different ways. Probably the most precise way is through a procedure called an insulin clamp, in which we infuse glucose and insulin at the same time. This is only done in an experimental setting, and we do it here all the time on the sit and floor. Some of the nurses sitting in the back are experts at this. They're research nurses. And this is a test that tells us how efficient is our muscle cells to take up glucose in response to insulin. And this is shown here. The y-axis is we call glucose infusion rate, and the higher it is, it means that person is more insulin resistant, more insulin sensitive, and the lower it is, in yellow, it means that those muscle cells are more insulin resistant. So this is a study we did several years ago, comparing people that were 26 versus 62 years of age, and as you can see, in this particular study, older subjects were more insulin resistant by about 50%. So why would the muscle cells in our body become more insulin resistant as we age? We don't know why this happens, but the prevailing hypothesis has to do with what we call a decrease in mitochondrial function. Now, I'm going to go back to your biology classes, which I'm sure you enjoyed for some years ago. So what are mitochondria? Mitochondria are these organelles that are in all the cells in our body. We kind of picture them as football-shaped organelles, shown here. Although in reality they're interconnected. They're like footballs, but although not shown here, they connect to each other, so they communicate by physically touching each other. Now, why are they so important? Because these organelles, the mitochondria, are basically the part of our body that makes energy for us. So we eat, of course, every day because we need energy, right? But what part of our body is making this energy is the mitochondria. So this mitochondria are taking up constantly all the different nutrients we eat, and they package it in the form of ATP, which is really the part of that is basically the source of energy in our body, ATP. So it has been hypothesized that as we age, the number of these organelles, of these mitochondria, goes down, and not only the number goes down, but also their function. So kind of this lazy mitochondria. So they cannot take up as many of those nutrients, sugars, carbohydrates, fat, and they cannot burn them properly, oxidize them properly to generate energy. And because of this, there's a buildup of all these nutrients in our body, and therefore they cannot take it up anymore. So it kind of, because they're lazy, there's this buildup, and there's higher and higher amounts of fat and glucose, etc., that has been built up in our body because they're not functioning properly. And not only that, but they're not making enough energy for our body. So is it that really true? So here, basically, this is trying to explain how this would work. So this here would be a muscle cell. So everything inside this would be a muscle cell. This is the outer part of the muscle cell, right? So how does insulin work in normal circumstances? So insulin will bind to its receptor. This is insulin. Binds to its receptor and activates many proteins that eventually make glucose to go in. So when insulin binds to its receptor in normal circumstances, activates all these proteins and then makes this, what we call glucose transporter, move from the inner part of the cell to the outer part of the cell. So when insulin binds to its receptor, glucose goes in because this glucose transporter called GLUT4 moves from the inner part of the cell to the membrane. So it's like a signal. It tells those GLUT4 transporters that are resting in the inner part of the muscle cell, okay, insulin is here, and then the transporter will go to the plasma membrane, and then it will start taking up the glucose here in pink. That's in normal circumstances. But as we age, as I mentioned, there's a buildup of, there's an increase in the amount of fat in the body, and the fat enters our body, and this fat gets metabolized into what we call toxic metabolites, called DAG and ceramides. So these are fats that are, as we age, start to build up in our body, and they're toxic to the cells. Meaning, when we put, instead of arrows, we put the symbols, these lines here, that means that inhibit. So these lipids inhibit the normal function of insulin as we age. And why would these lipids start to build up? They start to build up in part, we think, because our mitochondria don't function properly. So because they don't function properly, they start to build up. The mitochondria are responsible for burning these. And if they don't function properly, there would be a buildup. So how can we tell whether a person has fat in the muscle? One way is we can do a biopsy and measure muscle, right? The fat in the muscle. The other way to do it is actually by a method called magnetic resonance spectroscopy. That's basically the same principle as an MRI. MRI is magnetic resonance imaging. But here, the patient goes in the MRI instrument, just the same way as an MRI. But the software of the computer, instead of generating images as an MRI, it generates spectra. And by the shape of the spectra, it can detect whether a specific area in the body is fat or is it water. And it can also detect whether it's inside the muscle cell or it's outside the muscle cell. So it generates this spectra, which can be quantitated and tell us how much fat is inside or outside the cells in our body. So by doing this, it has been demonstrated that in older people who are lean and healthy, there is about a 2-fold increase in the amount of fat in those muscle cells. And by the way, the same happens in the liver and other tissues. So for some reason, our body, even if we're lean, accumulates more fat inside our muscle cells. And that's probably one of the reasons why our body tends to be insulin resistant. Now, these hypothesis which was generated mainly through animal studies. So what we wanted to test what happens in humans. So the question we asked is mitochondrial function reduced in older people. So we did a study in which we recruited healthy young and older people. So these are the age groups. In the younger group, their mean age is 25 years of age, and in the older group is 72. This is their body mass index, BMI. The older subjects were slightly, had a slightly higher body mass index, but they would still be considered non-overweight, although kind of borderline. Do you know the normal ranges of body mass index? Well, I guess some of you do, some of you don't. So basically, under 25, from 18 to 25 is considered normal. Of course, this varies with age, particularly in children. 25 to 27 is considered overweight. I'm sorry, 25 to 30 is considered overweight, and over 30 is considered obese. But certainly after 25, the risk of becoming diabetic increases significantly. So, these are healthy people. This is a measure of insulin sensitivity here, what we call an M value, and it's lower, showing that they're more insulin resistant. And what we wanted to see is whether these older people, their mitochondria function properly. So how can we get mitochondria for the muscle? Well, the most direct way is by doing a muscle biopsy. And again, our nurses in the back, they always help us with this procedure. So what you're looking here is basically the leg of a study subject. And of course, we clean very well. This is an aseptic technique. We put lidocaine in the area. With a scalpel, we do a tiny cut, and then we put this needle inside the leg. And you don't see here, but also there is a tube here that has suction, so there's a negative pressure there. So there's a tiny amount of muscle will go into the needle. And then we twist the needle to cut the muscle. Some patients feel it, but most don't. And we end up with about 200 to 500 milligrams of tissue out of the size of a pea, and then that's enough for us to measure what's going on in that person's mitochondria. So how can we measure the mitochondria? First, we need to isolate them. So we centrifuge this tissue, and then we end up with a solution of floating mitochondria. Of course, we can't see them, but we know they're there. And then with an instrument, we measure how much ATP, again, how much energy they can make. So this is when we measure how can they make alone, meaning without giving them any nutrients in the test tube. And then we need to give those mitochondria different nutrients so they can start rapidly making insulin energy, right? So these are different nutrients, which basically are the byproducts of what we eat. So just to remind you, your biochemistry, succinate, glutamate, malate, pyruvate, that sounds as biochemistry classes some time ago, right? Because those are basically the byproducts of what we eat, and that's what the mitochondria uses to make energy. So as you can see, regardless of the nutrient we give to the mitochondria and in the test tube, older people, even though they're healthy, they can only make half of the amount of ATP, meaning they can only consume about half of the amount of the nutrients and convert it in ATP. So that's a problem because, one, that person will have less energy, right? But also it's a problem because those mitochondria are not burning nutrients properly, and those nutrients are building up. And from a clinical standpoint, they build up in the form of obesity, right? Well, we not only are interested in trying to understand what's happening, but also in reverse it. So one logical way to try to reverse it would be through exercise, right? Because you can imagine, we know that as we exercise, we burn more calories. So we reverse this problem of aging with exercise. So we did an exercise study in older subjects where they exercised for 4 months. So this is shown here. These are people, we do not enroll athletes because, you know, athletes, if you enroll an athlete, you can't make it any better. They're just in so good shape. You need really to study people that are otherwise have a normal, a more typical lifestyle. So we enroll people that were generally sedentary but healthy. And then we start with a warm-up of a 1 week. But you can take someone who's sedentary and just tell them, start exercising every day for 40 minutes because they're going to quit, and second, they're going to get injured. They're going to get muscle sprains and ankle sprains and all kinds of problems. So for 1 or 2 weeks, we start very slowly with a 5 to 10 minute warm-up. Just stretch a little bit and exercise slowly, and we'll increase the exercise progressively. And we do this in the gym, and this is supervised. First of all, to make sure they're doing it, but second of all, also to make sure they're not having problems. If they're having problems, we need to ensure that this is done safely. So they start at what we call 60% of their maximal effort. So there's, like when you send your patient with a stress test, and they measure the maximal exercise capacity, basically, you know, what is the maximal that that person can do. So we do it, and then when you do that, that person gets what we call, it's called a Vo2 Max, a maximal exercise capacity. Typical exercise studies, these are done at 60 to 80% of the maximal capacity. 60% is what you would call a moderate exercise intensity. 80% would be moderate to higher exercise intensity. So they start with 63 times a day for 20 minutes, and we increase it progressively. By the 16th week, they're exercising at 80%. So, you know, they're exercising pretty hard for 4 days a week and 40 minutes each session. And then we repeated the measurements. So these are all measurements from older people before and after. So you can see that now the older people who, in the beginning, their mitochondria was only making half of energy compared to a young mitochondria, they basically doubled it now. And they basically reached the same level as a young person before exercising. So basically, when you're 75 years of age, your mitochondria will be working at 50% time, 50% compared to where you were younger. However, if you exercise, you can keep those mitochondria as working as if they were young. So, to summarize this part of the talk, as we age, our bodies tends to accumulate more fat inside and outside our cells. And these fat inside our cells impairs the ability of these cells to respond properly to insulin. This machinery that we have in our cells for insulin to work, that doesn't work as well as we age because there's a buildup of fat, in part. There may be other reasons we probably don't know yet. And this probably is explained by a decrease in the function and the amount of mitochondria we have in our body. That's the bad news, but the good news is that at least in the muscle where we've measured it, one can prevent this by doing exercise. Now, one would say, well, not everyone can exercise, and that's absolutely true. So one of the things we're doing is trying to elucidate what are those signals that exercise is stimulating in order to develop interventions that could be medications that will mimic the effect of exercise, kind of an exercise pill. But of course we don't do that to keep people from exercising. We don't want that because exercise has many benefits beyond this metabolic improvements. Exercise has, of course, very important effects on our bone, so it's important for prevention and treatment of osteoporosis. Has a very strong effect for prevention of cancer. Of course, the effects on the heart and our pulmonary cardiorespiratory system are very obvious. You know, you all have patients with have heart attacks and heart failure and COPD, etc. And exercising is beneficial. Of course, it has to be done carefully, but exercise is a very potent antidepressant. So if there's psychologists or psychiatrists here, you are well aware that there are trials in which exercise is almost as potent as antidepressants for the treatment of depression. So it's not that we don't want patients to exercise, but we recognize that not everyone can exercise, and therefore there might be benefits of developing an intervention that mimics the effects of exercise. Okay, now that I've told you about some of what we know regarding the pathophysiology of diabetes in elderly, and I'm saying some because my feeling is that there's a lot more we don't know. Now I'm going to give you some more practical recommendations regarding management of diabetes and the elderly. So the first question has to do, should we treat diabetes in the elderly? So probably the first impression you might have is, oh, this is crazy. If someone has a disease, we need to treat it. But let me expand this on this a little bit more. As I mentioned, the main reason, not the only reason, but the main reason we treat diabetes is because it leads to complications, blindness, kidney failure, neuropathy, amputations, and others. However, most of these complications take many years to develop. Depends on each person. It might take 5 years, it might take 10 years, it might take 20 years. And some people are actually protected from developing complications, and I'll talk about that a little bit more. So you might imagine that if a person is 90 and you're the physician or the nurse taking of a 90-year-old, you see them 3 or 4 times a year, and you know that person is not diabetic. But suddenly you see them, you see this person, and their blood glucose, instead of being 100, which is what you usually see, they come and it's 130. And as I mentioned, 130 kind of falls in the diagnosis of diabetes. So you say, oh, geez, this person is diabetic. We need to treat them. Let's bring the insulin because we need to treat this 95-year-old person. So you might say, well, why treat this person if the risk of developing complications, if the complications are going to take 10 years to come? You know, maybe this person won't develop complications. What is the whole purpose? So this has been a debate. You know, it's an ethical debate. You treat someone who, you might be treating someone who might not need it. So do older people who develop diabetes, are they more predisposed to developing problems than an older patient that doesn't have diabetes? So older people with diabetes compared to older people without diabetes do have higher rates of premature death, functional disability, high blood pressure, CHD, which is cardiovascular disease, and stroke. They also have higher rates. This is older people with diabetes versus older people without diabetes. They also have higher rates of what we call geriatric syndromes, which are polypharmacy, that is taking too many medication, depression, cognitive impairment, urinary incontinence, falls, and pain. So based on this, having diabetes, it does represent a problem for an older person. And the other thing you want to consider, that you should consider when making the decision, is that the age of a person per se is not a very good predictor of how long they're going to live. So just because a person is 70 or 60 versus 90, you can't really predict very well just by their age how long they're going to live. And this is shown here. This is a study conducted by Dr. Espinosa from the VA and Dr. Hasuda. It was called the SALSA study. And what they basically did is they studied, they took a large number of patients, hundreds of patients, and their mean age was 85 years of age, or 80. And then they categorized these patients, older patients, based on certain criteria of frailty. And they put them in 3 categories, either frail, which is on green, pre-frail on red, and frail, and not frail in blue. And then they followed them. There was no intervention. They just followed them for 5,000 days. How long is that? That's like 4 or 5 years?
It's like 15 years. 15
years. They followed them for 15 years. And then they saw how many patients remained alive throughout the course of time. So they wanted to see whether your baseline measurement of frailty predicts how long you're going to live. So not surprisingly, people that were frail did not live as long. So basically, 1, which is the top, means that everyone is alive, and then here, 0, it means that everyone in that group has died. So you can see people from that baseline were frail, they were dying at a faster rate than the pre-frail and the non-frail people. And that is not totally surprising. But the main thing that I wanted to show you is that here, let's look approximately here, which is 4,500 days, which is like 12 years. Only about 25% of the people that were not frail, let's assume a healthy person, had died. So if you're 80 to 85 years old, and you're healthy, and you would fall on the non-frail scale, the chance that you're going to live for 12 more years is 75%. So a healthy 80-year-old, that person could live for 10, 15, 20 years. So age, per se, is not a very good predictor. Of course, there are extremes. You're 150, or there's a chance that you're going to live. But age per se is not a good predictor. It's more important how functional you are. And that's one of the things to consider when deciding how to treat an older person with diabetes. And so the ADA and the American Geriatric Society, they get together and they make recommendations. Every 2 or 3 years they update the recommendations, and for the most they don't seem to change. So when you find that your older patient has diabetes, you need to decide, first of all, are you going to treat them, and second of all, how tight the control is going to be. What should you consider? 1 is a functional status, right? Is that person healthy? How is it able to do their normal life? Their life expectancy is not the same a person who has advanced cancer to a healthy person. Cognitive function, can that person understand what you tell them in terms of their diabetes? Are you going to give them insulin if they're cognitively impaired? Clinical heterogeneity, that's actually probably an under-recognized issue in diabetes management. That is, how prone to complications is that person? And of course we can't predict, but we can get an idea. We know that diabetes is bad because it leads to complications, but not everyone who's diabetic leads to complications. In fact, about 40 or 50% of the people that have diabetes don't develop complications. And you might say, wow, that's a lot of people that are protected from diabetic complications. And that is true, but there's also the other side, which is 40 or 50% that will. So it is a higher risk of developing complications, but it's also important to recognize that many don't. And why some do and some don't, it's not known, but very likely a genetic predisposition. So if you have a patient who only has had diabetes for 3 years, and you're noticing that they're spilling protein in the urine and they're having numbness in their feet, that's a person who's rapidly developing complications. You have a person who's had diabetes for 40 years, never really taking care of it, and there's not a single chance, there's no evidence of any complication whatsoever, that person is probably protected. And again, this is just a consideration. I'm not telling you to go out and stop treating your patients, but just something to consider. So in general, if a patient is functional, cognitively intact, and it has significant life expectancy, in general, it is thought to that the goals of treatment in terms of how tight is the same as a younger person. Probably around a hemoglobin A1c of 7 to 7.5. Most of you know what hemoglobin A1c level is, but just in case, a hemoglobin A1c is a measurement of hemoglobin that has been glycosylated, and it's a good measurement of glucose control for the previous 2 to 3 months. So if you want to know how bad or how good blood glucose levels in a person has, one way to do it, accurate way to do it, is with a A1c, hemoglobin A1c level. The normal is approximately 5.5 or less than 6. Over 6.5, you start getting into the pre-diabetic range, and over 7 is in the diabetic range. But these are not precise numbers. They're more useful for management of diabetes than for diagnosis. But in general, a younger person, the A1c goal is under 7, closer to 6.5. So if a person is older but they're otherwise healthy, etc., you probably should treat them as if they were young, with a hemoglobin of approximately 7. The ADA and AGS are leaning now towards being probably a little bit more conservative, towards 7 to 7.5, but somewhere around there. But if a person has decreased function, cognition, short life expectancy, the glycemic control can be relaxed. So if this older person has other issues to deal with, bigger fish to fry, as I've heard it sometimes, you probably can relax the management. Now, it's important to avoid hyperglycemic complications. What does that mean? If you have an older person who comes into your office with a glucose of 300, you should probably not tell them, oh, don't forget about your diabetes, go home, because that person can end up in the hospital with hyperglycemia and dehydrated, severe hyperglycemia and dehydrated in the next few days. So you do manage them, probably want to keep their glucose between 100 and 200, but don't forget about their diabetes entirely. Now, treatment for diabetes, I'm not going to go into insulin. Of course, insulin is used frequently for cases in which other agents have not been successful. There's also an argument whether insulin should be used earlier or not. I'm not going to get into that because I don't think there's a right answer. So I'm going to go over some of the other agents that are more commonly used for diabetes and some considerations regarding aging. So based on what I showed you before, there are pathophysiology of diabetes. There are the agents that we've used for the most, which are called the sulfonylureas. These are glyburide and glyphosate, and they work on the pancreas. They make the pancreas release more insulin. They don't make the beta cells more healthy, but basically stimulate the beta cells to release the insulin they have in kind of a dysregulated manner. So when you that person takes the glyphosate goes to the beta cells, and it makes those beta cells release all or most of the insulin they have. And then the beta cell makes more insulin, and the next time the person takes the drug, it just releases them. Kind of a dysregulated manner. Then we have drugs that work in the liver. As I mentioned, the liver in diabetics is constantly making glucose. So we want to decrease the amount of glucose. Here, HGP, hepatic glucose production, it's increased in diabetics, and we use drugs that decrease that. The prototype is metformin. That works mainly in the liver by decreasing the amount of hepatic glucose production. The other drugs that work here are rosiglitazone, that is not used very frequently because of some cardiovascular concerns, and pioglitazone, that is shown here, that both work to some extent in the liver. Now the other important part is the muscle, which in insulin resistant and diabetics, the amount of glucose taken up by the muscle will decrease, so we want to enhance that. Metformin has a small effect in the muscle. Then rosiglitazone and pioglitazone are much more potent at the level of the muscle, and they increase the amount of glucose being taken up by the muscle. So that's why they're called insulin sensitizers, because they enhance the effect of insulin at the muscle and the liver. There are other newer drugs that have different mechanisms of action. One is what we call incretin mimetics, and I'll talk about a little bit more about that, but those exenatide, and there are others coming out. There's another one in the market now, but I'll stick with the exenatide for now. These are injectable drugs, and they work by mimicking the effect of a gut hormone called GLP-1. And I'll talk more about that. And the other one is DPP-4 inhibitors, which are those oral agents, and there are now 2 in the market, and several more that will come soon. And basically, they also enhance the activity, the levels and activity of this gut hormone called GLP-1. Okay, so sulfonylureas, that's glyburide and glyphosate. They stimulate insulin release. Again, they don't make the beta cells healthier, just they make them kick out the insulin they have in them. They're very effective, or as effective as any other oral agent. They decrease A1c by 1.5 to 2%. So they're really, so far, there isn't any other agent other than insulin that is more potent than sulfonylureas. Now, they have some problems. They tend to cause weight gain because they increase insulin levels, and insulin causes weight gain. The major problem is hypoglycemia. So the incidence of hypoglycemia is anywhere from 1 to 20%, depending on the patient and the study. And that can be a problem, of course. Most of the cases it's mild, but it can be severe. So there are patients that die or end up with severe neurologic damage due to hypoglycemia. So that's an important consideration. Sulfonylureas have different half-lives. Half-life means how long they stay in our body functioning. So you can see that these sulfonylureas have a different half-life. Some very long as chlorpropamide, although this is not used very much. The ones that are used more in the US are glyphosate, glyburide, and glyburide, and they have different half-lives. Because as we age, our body, our kidneys, and our liver becomes less effective in metabolizing drugs. In general, the half-life of most drugs increases as we age. And because hypoglycemia is a problem, and even more of a problem in older people, we like to use short-acting sulfonylureas in older people. So if you're going to give a sulfonylurea to an older person, you should probably give them glyphosate because it's a shorter acting. Okay, metformin. Metformin works through decreasing the amount of glucose being produced by the liver. It is as effective as sulfonylureas. It can decrease A1c by 1.5 or 2%. It has several benefits or advantages over sulfonylureas, although commonly we use them together to enhance their effectiveness. But metformin doesn't cause weight gain, and in fact, in many patients, it causes weight loss. Not large amounts of weight loss, but anywhere between 1 to 5 pounds. When used alone, doesn't cause hypoglycemia. In very rare cases, if a patient is malnourished, or if a person exercised and didn't eat anything, so this post-exercise hypoglycemia that can happen, it can be worked with metformin, but it's very rare. Metformin by itself almost never causes hypoglycemia. Now, considerations with aging. As I mentioned, the metformin is cleared. As we age, the ability of our kidneys and the liver to clear drugs decreases, and the same happens with metformin. So, many of us have been taught to be concerned of lactic acidosis with metformin. What is lactic acidosis? Well, what is lactic acid? Lactic acid is a byproduct of glucose metabolism, and we all have some lactic acid in our cells and in our blood, and if it goes very high, it can cause acidosis, of course. And in very rare cases of patients who take metformin, particularly patients who have other severe problems such as sepsis, kidney failure, liver failure, congestive heart failure, metformin can increase the risk of lactic acidosis, and even leading to death. Now, this is very, very rare, and usually happens in cases with other problems. So, I would encourage you not to be afraid of metformin in older people. What you do have to do is make sure that the patient's kidney function is normal. Not only in older people, in everyone. So typically, before you give metformin to a person, you want to make sure that the blood creatinine, which is the plasma creatinine as a measure of normal kidney function, is normal. And the typical way to test kidney function is by measuring plasma creatinine. And in the case of metformin, if it's 1.4 or higher in a woman, that probably indicates that kidney is not functioning very well, so you don't give metformin to that woman. And in the case of the man, if it's 1.5 or higher, the plasma creatinine used, you don't use metformin. One issue has to do whether plasma creatinine is a good measure of kidney function in older people. And so where does creatinine comes from in our body? It mainly comes from the muscle metabolism of muscle proteins. So if a person has a small amount of muscle, like a very frail older lady or very frail older man with a small muscle, typically they have very low creatinine, 0.4, 0.5, because they have small muscle. So if you have an older person with a small amount of muscle, and you see their creatinine at 1.5, that's probably meaning that their kidneys have not functioned properly. So if a person is 80 or higher, their recommendation is to do a formal testing of kidney function of creatinine clearance and not relying on the plasma creatinine. That's the kind of the formal recommendation. A lot of people don't do it, a formal measurement, but in general, you want to make sure that the person has normal kidney function if they're older. Contraindications for metformin and congestive heart failure, renal and liver disease. TCDs, pioglitazones and rosiglitazones. So they work through a protein called the PPAR gamma receptor. They improve the function of insulin in muscle and liver, therefore we're called insulin sensitizers. They are probably as potent as sulfonylureas and metformin alone in terms of reduction of A1c. The main concern it has to do with weight gain and swelling. So weight gain and fluid retention is common on these patients. An advantage over sulfonylureas is that also hypoglycemia is very rare. So so we're taking alone almost never. It probably works as well in older people as in younger people. Some things you want to do is just check liver functions periodically. The main issue with them is the fluid retention. So if a person has any evidence of congestive heart failure, pulmonary edema, you absolutely should not use them. If a person has swelling or edema, you should probably try to stay away from them. If you decide to use them when a person has mild edema, it's probably okay, but just start with low doses and follow them closely to make sure that person is not developing severe edema or congestive heart failure. And again, low doses is probably fine. Don't use it if a person has elevated liver function tests. Okay, and newer drugs that are now in the market, and they work through what we call the incretin system. Incretins are hormones, peptides produced by the gut. And the most one of the most important ones regarding treatment of diabetes is called GLP-1. So again, this is a hormone produced by the gut, and it has important effects in our body. This hormone, and it's naturally produced by the gut. It slows down the emptying of the stomach, so you can envision how that can be helpful for diabetics. If the glucose that is coming into the stomach is absorbed slowly instead of fast, now the rising glucose, it's more manageable for the body. It increases the amount of insulin released by the beta cells and decreases the amount of glucagon, which is another hormone made by the beta cells. And that in concert helps to maintain glucose levels. And interestingly, it does it in a more regulated manner than sulfonylureas. A sulfonylurea is going to make those beta cells release insulin regardless of the glucose concentration of the patient. Meaning that even if a person has a glucose level of 80 and you give him a sulfonylurea, those insulin levels are going to increase and the person will probably become hypoglycemic. However, these GLP-1, well, the way the beta cell respond is differently, meaning that it will release insulin, but only if needed. Meaning if a person has normal glucose levels, let's say 70 over 80, and the person gets a GLP-1 analog, or if one gives GLP-1, those beta cells will say, hey, come on, this is a mistake. I'm not going to release insulin. This person doesn't need it. So it's a more regulated manner. It also suppresses appetite. So people that are taking these drugs that work through this system tend to eat less and lose weight. This hormone, again, made by the gut, is also cleaved and metabolized, broken down in our blood by an enzyme called DPP4. So how can you use this hormone for the treatment of diabetes? One is you can give it directly to the patient. Now the problem is that this enzyme DPP4 is very fast. We have a lot of it in the blood. So if you give it to a patient, this enzyme will go and break it very fast. So that won't work. So what drug companies have done, and they did it by studying the saliva of the Gila monster, they identified a protein that works just like GLP-1. So that's a drug called exenatide. So you're not giving GLP-1 to the patients, but you're giving a drug that works just like GLP-1. and is protected for being broken down from this DPP4 enzyme. So that's called exenatide. The other way to do it, to increase the levels of this hormone, is by actually inhibiting this enzyme, right? So if you're inhibiting the enzyme that breaks it down, you'll you'll end up with higher levels. And these are shown here, the drugs that work through this mechanism. One is exenatide, which is usually given twice a day, or there's a long-acting form now once a week in the market. The other one is called liraglutide. It's once a day. They're probably as effective. As I mentioned, they are agonists, meaning they mimic the effect of this hormone, GLP-1. They increase insulin release and inhibit glucagon. They delay gastric emptying. They cause significant weight loss, even more than metformin. It almost never causes hypoglycemia unless used with insulin or sulfonylurea. Now, the main problem of these drugs is nausea and vomiting. So, approximately 25 to 40% of patients will develop some nausea. And that in part explains why they lose weight. Not all patients that lose weight have nausea. So, but it is a concern. And certainly if a person, if you're treating an older person who's malnourished and doesn't want to eat well, and it's probably not a drug you want to give, right? And it is not clear yet, but it seems like it works as well in older people as younger people. Yes? Vieta is exenatide. Exenatide, yeah, Vieta is the commercial name. Yeah. And then the other family of drugs that, again, work through this system is called DPP4 inhibitors. These are taken up. These are all injectable. These are oral. And again, these inhibit the enzyme that breaks down GLP-1. They're given orally, usually once a day. And there are 3 now in the market, shown here. Sitagliptin has been in the market for now 4 or 5 years, probably 5 years. They have the same, in general, they have the same effects as these, but just they're less potent in reducing and improving, in reducing glucose levels. They're also not, they're almost never cause weight loss, but they don't cause weight gain either. So they're kind of weight neutral. But they're much better tolerated. There's really no nausea associated with them. So that's, of course, and then they're very safe in the sense that there are really no major adverse events, other than allergies that can happen with any drug. But in general, they're very safe, very well tolerated. And they seem to work as well in older people and younger people. And in fact, there is a push to use them in older people more because of their safety. But again, that's still questionable. Okay, so now I'm going to go through some cases, and I'd like to get your input. And again, this is just an open forum, so don't be ashamed of say whatever you want, or don't be shy. Because there's no one right answer. This is just some cases for discussion. So and these actually are real cases that I had. Had a 75-year-old man diagnosed with type 2 diabetes since he was in his mid-50s. He had not seen a doctor regularly, maybe here and there, for 4 years. He remembered taking glipizide and then insulin at some point in his life, but nothing in the past 6 years. He's very active and works. He drives a truck and distributes produce throughout the city. Very energetic man. He does have a history of hypertension, so he takes hydrochlorothiazide. He's overweight. His BMI is 31. His blood pressure is a little higher than we would like, but not terrible. We performed a detailed exam on him. There's no retinopathy, no neuropathy, just a little bit of swelling in the legs. His creatinine is normal. His urine albumin and creatinine is 25. so the normal is less than 30. So it's not bad, but kind of in the limit. His A1C is high, 9.7, so evidently he is diabetic and he hasn't been taking care of himself. His glucose 289. His LDL is 132. So in diabetics, probably the recommendation is lower than 100. Certainly less than 130, and in most cases lower than 100. So it's kind of high for him. His HDL is low for him, 32, and triglycerides are high, 272. So would you treat him? How tight would you treat him? What A1C would you want to have him? And what agent would you use? So, who would absolutely wouldn't treat him and say, forget about your diabetes? Okay, good. Now, who would want to tell me what diabetes agent would you use and what A1C target? Some ideas. And volunteers? Yes?
Metformin, since his creatine's okay.
Okay, good choice. And what else? What other reasons?
Probably A1C at 7, since you said that he's...
Okay, so it's effective and will bring down his A1C probably down by about 1.5 to 2%. So that's, yeah.
Since he's a truck driver, I know out of state they can't take insulin. In state, I'm not sure.
Okay, yeah, so that's probably a reasonable, a very important thought. You know, a truck driver who's probably not very compliant, you don't want to give him insulin, right?
Right, so maybe, you say glucosamine or shorter-acting, glucosamine, you said glucosamine.
Yeah, okay, so probably sulfonylurea, yes, also for a truck driver who, let's say sulfonylurea can cause hypoglycemia for a truck driver who is probably not very compliant. You don't want that, okay? So metformin, I like that idea. What else? How about this? Yes?
Since he's overweight.
Exactly, yeah, so it's overweight, that'll might,
Once a week, exenatide, by doing it.
okay,
Because if he's gonna only not be very compliant, that can help with weight loss plus his state.
okay, yeah, so.
Risk of hypoglycemia when he's out driving the truck.
Okay, yeah, so yeah, the lady in front is also saying about once a week exenatide, which will help him with his weight, right? So, yeah, so I think metformin is probably the ideal drug for this patient, and in fact is the drug of choice for patients with new onset type 2 diabetes that need an oral agent because it's as effective as any other drug, is very safe. As long as the patient doesn't have renal failure, it will be weight neutral and in many cases cause weight loss. It tends to improve the cholesterol levels. It's not a true cholesterol reducing agent, but it tends to improve levels slightly. And it also good data about its cardiovascular mortality. So of all the oral agents for diabetes management is probably the one we know has better cardiovascular profile. Yes?
I would also make sure he doesn't see the diabetes educator, because he's driving a truck, he's probably stopped at the truck stop, give him some idea of what to be buying, for meals. The other thing, he's 75 and still driving a truck, either he's very high energy, or he needs money. Exenatide or Bydureon's very expensive, so it depends on whether or not he has insurance.
Well, absolutely, and I'm trying to stay away about cost because although that's a very important consideration, but yes. So lifestyle intervention is very, very important, and anyone who has diabetes, and probably anyone, regardless of whether they have diabetes, should be seen by a nutritionist regularly, and nutritional interventions and exercise can be quite effective. I'm trying to focus here on the pharmacology because I know that's what you probably don't see that much often in your talks, but that is a very important thing, and thanks for reminding me. In terms of exenatide, actually, I think that is not I think that's a great add-on with metformin in this case. I would start with metformin, again, because there's good evidence, long-term evidence of safety and also reductions in cardiovascular events. But for an add-on, I think exenatide is a very good choice, or any from those family. Now, if a patient does comply with their diet and get metformin, we might bring their A1C down to the 7.58 range. And as I mentioned, remember I mentioned clinical heterogeneity, meaning that not everyone develops complications. So if that person has had diabetes for 25 years and hasn't developed this poorly controlled diabetes for 25 years, hasn't developed a single complication that we can tell, the probability that he will develop complications with an A1C of 7.5 is fairly low. So, considering his lifestyle and you know his occupation, I would probably shoot for an A1C of about 8, 7.5 or around that. So. Of course, something we haven't mentioned, other important issues that have to be addressed is the blood pressure and his cholesterol, right, which those are high. And that's big, huge risk factors for cardiovascular disease. Okay, now, 76-year-old woman diagnosed with type 2 diabetes for the past 4 years. She has a history of osteoporosis, takes alendronate for that, no diabetic medication. She walks 30-45 minutes every day. She's very active, a very active social life, lots of friends, family, very happy person. BMI 22, so she's not overweight. Her systolic blood pressure is high. And she's quite sure she sees her doctor regularly, so she's sure that she's only had diabetes for 4 years. And she has a few microaneurysms on the eye exam, and she looks a little, some muscle wasting, you know, a little frail, but otherwise healthy. Her creatinine is normal. Her urine albumin creatinine is ratio is 53. As I mentioned, normal is 50, is less than 30. And this ratio, the amount of albumin in the urine is an early marker of kidney disease. So kidneys, when they start seeing the damage of diabetes, the first thing, one of the first things that happens is that they start leaking protein, albumin. So this person has evidence of that. A1C is 8.1, so it's not very high, but it's abnormal. Glucose is elevated, 174, normal cholesterol, and no GAD antibodies. GAD antibodies are positive in type 1 diabetes. So because she's very thin, her primary care doctor sent her to me. He was concerned about type 1 diabetes at some point and measured these antibodies. They were negative. Do you have to measure antibodies on someone you suspect type 1 diabetes? You don't, but it sometimes can be useful, particularly if you want to decide whether this person needs to be treated with insulin. At any rate. So who would tell this person, oh, don't worry, you're 76. Why do you care about diabetes? Just go enjoy life. Okay, good. I like that. We have here acute osteoporosis, and there is some new emerging evidence that the glitazones, 5-glitazone and rosiglitazone, might decrease bone density. There's no evidence that they cause fractures or osteoporosis, but I think the evidence that it doesn't decrease bone density is pretty solid. Okay. All right, so who would give this lady, let's say, who would give her metformin? Okay. No metformin. Why? Well, yeah, that's a good point, but I'm just going to clarify. having protein in the urine itself is not a contraindication for using metformin. And I know that might be a little bit confusing. The creatinine is normal, so we can use metformin. The reason I probably would not give her metformin is that she has some muscle wasting and she's thin. So metformin, as I mentioned, can cause some weight loss, and some people can actually decrease appetite. You probably don't want this person to lose more weight. And again, I'm saying probably because a small amount of metformin might be okay, but I wouldn't push it in this person. Who would give her exenatide? Give her shots of exenatide? Probably not, right? Because if you want to suppress her appetite, and again, this person should probably not. And again, who would tell her, go to, what you need to do is exercise more and go to the dietitian? Well, I would ask her to go to the dietitian, but not necessarily with the idea of having her lose weight. And exercise is always really walking 30 to 45 minutes every day, so it wouldn't hurt her if she starts riding her bike. I mean, I wouldn't tell her don't ride a bike, but chances that that's going to have a huge impact is. I would. Who would give her? Okay, let's see. So let's see. What choices do we have? We said metformin, maybe a small dose. But okay. Good. So I mentioned the pioglitazone. When actually back then, when I had this patient, we didn't have we didn't know what we know now about the bone density. So I actually gave her 15 milligrams of pioglitazone, which worked very well. So pioglitazone, I wouldn't say. Well, I probably wouldn't give her, knowing that she has osteoporosis. But if she wouldn't have osteoporosis, it could be a good choice because it's not going to make her lose weight, it's not going to cause hypoglycemia, and it might bring her down to the 7 range. And I put the fact that she's only had diabetes for 4 years, again, to underscore this issue of clinical heterogeneity. Just as the other person had diabetes for a long time and seems to be protected, this person has only had it for 4 years, and she already has microalbuminuria and microaneurysms. So we need to be more careful with her. So I probably would want to have her an A1c closer to 7, and not 8 like the previous person. And also the fact that she has an active social life and she's very healthy, the fact that she might live up to be 90, 95, so we shouldn't forget about her. So I like the idea of the DPP-4 inhibitors because they don't cause, they're very well tolerated, it's not going to make her lose weight, and it's not going to affect her bones, and it might bring her down to the 7.5 range. She might need something else, so perhaps a low dose of metformin with with a DPP-4 inhibitor. Okay, this is another case I had, a 64-year-old woman diagnosed with type 2 diabetes 1 year ago. She has end-stage pulmonary fibrosis, not from smoking, but more from just an idiopathic disease. She takes oxygen at home. She takes glargine, long-acting insulin, 15 units at bedtime, and a sliding scale of Listro, 3 times a day based on her pre-meal insulin. She lives with her daughter. Her daughter takes very good care of her. She's very concerned about her mom. The patient is on a wheelchair. Her BMI is 23, so she's not obese. Normal blood pressure, her O2 saturation, even with oxygen, is low. It's 89%. I'm sorry. No retinopathy, no neuropathy. She looks cyanotic. Normal kidney function, A1c 6.1. Her Her daughter, again, she's a very caring person, but she's really worried about her diabetes. So she checks her glucose and tries to just give her high food with a lot of calories and carbs, very tight, monitoring her insulin. So her glucose is normal and her cholesterol is normal. So who would maintain the same regimen?
I have to know, is she having any hypoglycemia at all? Any signs and symptoms of hypoglycemia? That would be the first.
Not really. No. You would, okay. All right. So who would, and that's fine, who would use something different? Okay. So this person, what is the life expectancy of a person with end-stage pulmonary fibrosis?
2 to 5 years?
Yes, probably less. Oh, you're right, maybe a couple of years. So the risk of developing complications before this person is going to die it's low. Who would maintain the strict nutritional management the daughter who's doing it in good faith is doing?
Let me comment on that. One thing I've seen with people who have chronic disease that they're dying from, and if the family member is very attentive, this is something they can control. And so as long as she's not hypoglycemic, I guess I would make sure that we would discuss it with the daughter and the patient and determine what they want to do. If they want to just drop off the Lispro and just keep a little glargine on, she's probably not being able to eat well because of the lung issues. And so, that would be something that I think that would be a daughter-mother decision that would be made. So.
And I think you probably mentioned that the most important part of this talk, that ultimately diabetes treatment, the choice of diabetes treatment is made by the patient. One gives them the information and tries to guide them, but you're absolutely right. The decision is probably going to be made by the mom and the daughter. By the person and the daughter. In this particular case, the patient did feel like there were things she was not eating that she would have wanted to eat. I asked the daughter to relax, basically let her eat whatever she wanted. I asked her to maintain the glargine, 1 shot a day, but remove the frequent injections. And again, that was something that I discussed with them, whether she wanted to have less injections than she felt she did. And also only check her glucose instead of 4 times a day, check it once a day. And not worry too much in this particular person about the glucose levels, but if they were over 250, just give me a call. So I think what you basically said is the most important, that you give them the information and let the patient decide. In this particular case, it also is kind of the contrast to the other 2 cases in which life expectancy, I consider the life expectancy on this particular person. And let me see, I think this is the last thing I have for you. Okay, yeah. Well, thank you. Any questions? Yeah.
I like the wheelchair idea, because if she's cyanotic, she's
I'm sorry, I couldn't hear you.
okay, I like the wheelchair idea, that she's cyanotic, so and fatigued, and so.
Oh, absolutely.
She probably can tell
Yes.
when the daughter's there.
I think we have some time, right?
Yeah, there's more time for questions.
Yes.
Are there any data that suggest that coenzyme Q may help with mitochondria or diabetes at all?
Coenzyme.
Coenzyme Q.
Oh, okay.
Pre-diabetes.
Oh, okay, yes. So the question is whether any data coenzyme Q can improve diabetes. So I guess there's this product, coenzyme Q, that is sold in some places with the idea that it might have beneficial effects. To my knowledge, there is no data in humans suggesting that it would improve mitochondrial function or diabetes. Doesn't mean that it wouldn't. I just don't know aware of any data. No? Anything else? Okay. Thank you.
Okay, ladies and gentlemen, let's go ahead and take about a 20-minute break. Go ahead and use the restroom and get up and stretch and walk around, and we'll resume after the break around 10:15 or so with Sarah Espinoza. And again, we'll start with Helen Longdale. And we'll resume in about 20 minutes. Thank you.